welcome everyone. My name is Dr. Christina Brown. I'm a pediatrician in Baltimore. I work at the Kaiser Permanente Center in White Marsh. I'm joined by my incredible colleagues, Dr. Patton Smith and Dr. Coe. October is ADHD Awareness Month. So in honor of that, we're excited to talk to you today about ADHD, or Attention Deficit Hyperactivity Disorder. As doctors who care for pediatric patients, we get a lot of questions about ADHD, including symptoms, diagnosis, how to treat it the best. So we're here to answer any questions that you may have about it. So Dr. Coe, why don't you introduce yourself first, please?
Hi, I'm Dr. Coe. I'm a developmental pediatrician and I practice at Kaiser Permanente in suburban Maryland at the Shady Grove Medical Center.
Great.
And hi, everyone. My name is Dr. Patton Smith. I am a child, adolescent, and adult psychiatrist, and I practice in the Northern Virginia service area. Happy to be here.
Thanks so much. So excited to talk to you all about this today. First, why don't we start to talk about Dr. Patton Smith? What is ADHD? What does it look like?
So ADHD, the way that I look at it and explain to patients, it is a learning style that crosses a lot of different focuses. So people with ADHD are seen in neurology, in developmental pediatrics, in internal medicine, in family medicine, and in psychiatry. And basically, it is where people have difficulty in figuring out what's important and what's not important at any given time. The way we're wired, we're only using about 2% of our brain at any given time. So when people have ADHD, they're trying to focus on everything coming out at them. The challenge is our brain kind of cheats, so it's difficult sometimes to do that. So things get missed, and that's part of the challenge. So people have difficulty with focus, attention, concentration, impulse control. Some people have issues with hyperactivity. All of that is part of the cluster that is attention deficit hyperactivity disorder. The thing of deficit is somewhat interesting because it's not necessarily a deficit, it's kind of an abundance of sometimes focus and trying to focus on everything. But that's how I usually explain it.
Great, thank you so much. Dr. Coe, what would evaluation and diagnosis look like?
Well, so the tricky thing about this diagnosis is that there's not really any specific lab tests or imaging studies. Like there's an absence of biomarkers that makes it tricky to diagnose. So essentially it's like a clinical diagnosis, and we rely heavily on the history and observations, what we're seeing in the office. And so the evaluation would involve scheduling a visit where we gather information, get the history. Most of the time it would involve collecting information after the visit from the teacher and the parent using questionnaires. And so in order to make the diagnosis, someone has to be showing a certain number of symptoms to a certain level of severity across more than one setting. So that's why we sort of need the information from more than one respondent. But it's important that even though questionnaires are a big part of how we gather the information, we don't diagnose based off of those numbers. So really it is about like an overall clinical picture, what we're seeing in the level of impairment and functioning. And there's a few key times in a child's, I guess, in their early life that we would maybe see the symptoms come out, or we tend to see them present. So if it's more significant or severe, we may see symptoms as early as kindergarten, because this is the first time the child is in a structured like classroom setting with an actual academic curriculum. And the other point in time would be maybe third grade. That's when children, they have the switch, which is switching from learning to read to then reading to learn. So the demands increase, and sometimes we may see symptoms come out then. And then otherwise, any other big point of transition, like into middle school or high school or even college, we may see the presentation come out then. And then the other thing, just going back to assessing the symptoms in if they're happening in more than one setting. So if it's that a child's having symptoms in one setting but not the other, it is very likely that we're not dealing with ADHD. So for example, if a kid has the symptoms in school but not really at home, things to consider there would be like, well, maybe there's a learning issue, or maybe there's like a cognitive delay or some sort of intellectual disability. You know, if like I was having trouble learning, yes, it would be hard for me to pay attention too, right? So then it could present like ADHD. On the flip side, if it's happening only at home, but not really at school, well, then you would want to consider maybe there's like specific stressors going on at home, or there's something going on as far as like the parent-child interaction. You know, maybe there's the expectations a parent has for their child is unreasonable for their age, and the parent's just, you know, unaware. So those are some things to consider when making the diagnosis.
Yeah, so it sounds like we need a lot of information from the school, work closely with the school and the teachers to figure out what's going on there and combine it with what the parents are noticing. Do you see a difference in how, you know, boys versus girls will present with it, Dr. Cohn?
Yeah, so this diagnosis does tend to have male predominance. The numbers, or the ratio, is about 3-to-1 males to females for the combined type. But the thing is, girls are more likely to have ADHD inattentive type, because this diagnosis kind of comes in 3 flavors. So you have the inattentive type, or you have hyperactive impulsive type, or you have combined, which is symptoms of both. So girls, they tend to have the inattentive subtype, and the numbers there would be like, it's a 2-to-1 ratio as far as males to females. So that one, you know, does tend to happen more with the girls. And then it makes it tricky to diagnose, because when there's an absence of disruptive behaviors, which we would see more typically with the hyperactive impulsive symptoms related to ADHD, then it can be harder to recognize. And then the other tricky thing about this diagnosis is that young children, they're naturally more active, right? And that's within normal. And they naturally have, you know, underdeveloped frontal lobes, which is the area that controls a lot of these symptoms related to ADHD. And so that can also make it tricky to diagnose.
Yeah, yeah. So kids can scoot under the radar depending on what symptoms that they're having predominantly. Dr. Patton-Smith, is evaluation and diagnosis any different for you?
Not really. It is extremely important, as Dr. Koh said, to focus on what's happening at school. That has to be part of the equation, but we're looking at how they're doing socially, how they're doing at home, and how they're doing at school. And as Dr. Koh said, we don't have any biomarkers, so we are getting information from the school, usually through checklists and such. So another thing that we're looking at when we are diagnosing is what's in our differential. So what are some other issues? Because someone having challenges with concentration doesn't equal ADHD. And I always tell parents that it could be, as Dr. Koh said, learning issues or some cognitive issues. It could be underlying depression or anxiety. It could be social challenges with regard to what's happening in the classroom. It could be just dealing with and adjusting to a change in a classroom or a change in a school. So all of that may be part of it. So we make sure, just like fever doesn't equal pneumonia, we make sure that we're really looking at all the options when we're looking at these symptoms to make sure we're clear on what our diagnosis is.
Yeah, I think that's a really great point, because I got a huge number of teenagers early in the pandemic when they were
Yes.
doing the virtual learning say, I think I have ADHD, I'm having trouble focusing. Like, this was a huge change in your life that you've gone through now. We have the stress, the anxiety of the pandemic, you're worrying about your safety, you're not able to, you know, focus on your schoolwork when you have your cell phone, your computer right there. It's really hard to focus, but it's not necessarily ADHD. So that's a great point. Dr. Patton-Smith, do you feel like kids can outgrow this over time? I hear parents ask about that. Like, we don't need any treatment, like they're gonna outgrow it, you know, when they get bigger.
So you always have this learning style, and it will be always challenging sometimes to figure out what's important and what's not important. A lot of times I have parents that bring their kids in for an ADHD evaluation and they say, well, I used to have it, but I don't have it now. A lot of times they still have it. What they equate is medical treatment for ADHD, which you don't always need. For some patients, especially those that are really hyperactive, as they grow and develop and their prefrontal cortex matures, they are able to decrease hyperactivity significantly, even without medication. So the other part to that is, as a person grows and develops, they have more consciousness and ability to maintain their surroundings. So as you're moving into college, there may be certain types of classes or certain college life or schedule that works better for you. The same thing as you're moving into a job or the workforce, which may mean that you do still have trouble focusing, but you're able to handle it based on your structure and your lifestyle. So it's a learning style that stays with us, but it doesn't necessarily mean that it has to be treated with any medication ongoing.
Yeah. So, Dr. Patton, what would you say are the most common ways that it gets treated, and how do you decide that someone's ready for a medicine?
So we typically use two types or two classes of medicine, and we're going to be very general with this: stimulants and non-stimulants. So stimulants directly increase dopamine and norepinephrine, two chemicals that are throughout the body, but we are most noting them in ADHD because we need the dopamine and norepinephrine to get to the prefrontal cortex. That's where you do your focus, attending, planning, maintaining impulse control. So executive functioning, which you hear a lot about. The non-stimulants also increase dopamine and norepinephrine, with the exception of one. And what they do is indirectly increase those chemicals. So we're dealing with the same neurotransmitters, the same chemicals. It's just a matter of, with the non-stimulants, it takes a bit longer for the dopamine and norepinephrine to get to the prefrontal cortex to notice any effect. The stimulants typically work relatively quickly and do not last longer than a day, basically, usually a 12-hour period or so. So stimulants work right away and end by the end of the day, whereas non-stimulants are like more traditional medications where they build up in the system over time and last for a longer period of time.
Yeah, so it sounds like with the stimulants, you wouldn't necessarily have to give it every day, right? So some patients you're able to stop it on weekends or
Exactly.
summers if they're not having
Exactly.
to stay.
And that is one of the positives of a stimulant, is that it's not like the traditional have to take it, let it build up. For a lot of my kids, they take what we call drug holidays. So they only take it on school days or don't take it on the weekends or during the summer to allow their brain, body to rest. Because with the stimulants, all drugs have side effects, but with stimulants, a lot of times we see sometimes decreased appetite, we see sometimes decreased sleep, and that obviously can affect focus, attention, concentration, and overall balance and well-being. So it's extremely important that in these situations, especially, drug holidays are taken.
Yeah. Dr. Koh, can you talk about some non-medical ways it's treated?
Well, yeah, sure. But actually, before moving on from medication, there's just a few things I wanted to add. So the one thing that I don't think many people realize about stimulant medications is that there's actually a ton of different formulations. There's ones that are designed to last like maybe 3 to 6 hours versus the intermediate acting ones that are like a little bit longer, and then even longer acting ones. And so they all kind of have their own different purpose. And the other thing to keep in mind is that a lot of times when starting a medicine, it does involve a lot of trial and error, because unfortunately, though we know like a general side effect profile, we don't know how each individual will respond to the medications. And so it does involve some trial and error. The positive is that there's many different options. So, after the first one, that's not the end of the line. And, generally it's just about weighing risks and benefits. So as far as non-medication treatments or approaches, well, I guess I should say that I don't like to separate it so much, because essentially tackling ADHD is a multimodal approach. So it's most likely going to involve medications as well as some of these non-medication strategies. And so when we're not talking medicines, then it would be things like behavioral interventions, as well as like environmental modifications or accommodations. So if we're talking behavior therapy, so this is actually the first line treatment in a preschooler with ADHD. That would be someone less than 5. And the earliest that we would make a diagnosis is 3. So it's those that are 3 to 5 with ADHD. So first line is behavior therapy. For ages beyond 5, behavior intervention is still recommended, but it may look different just because it's like, addressing a different age. But what the behavior therapy is the therapist would work with the child and parent. So it's very much a family, a team approach, right? On evidence-based strategies for behavior modification, things that have been shown to work. So a lot of times it will emphasize things, like contingency management, like basically helping the child decide like, well, if I do this, then this will happen, and realizing that those kinds of payoff, structures are worth it, It's also going to help focus on things like, it'll help shape behavior through modeling. It's also a heavy focus. And the important thing to note is that they have been shown to be effective. But very much so, it falls on the parent a lot. So the therapist is working a lot with the parent, not just with the child, especially when the child's young, because, a preschooler, it's going to be harder for them to participate in behavior therapy. And so, the parent would learn things like how to deliver clear commands or how to adjust expectations so that they're developmentally appropriate, how to decrease negative interactions to like minimize arguing or repeating commands over and over again, these kinds of things, implementing like a token economy system, or how to effectively use the timeout. So there's a lot of places that a timeout could go wrong. And I don't think many parents realize that there's something, about the timeout process that could be adjusted. So those are some examples of what behavior therapy could accomplish. But if, in talking about other non-medication treatments, it would also include things like parenting groups. And this is recommended because it would reduce feelings of isolation. I think that when you're dealing with challenging behavior for a parent, it can be extremely isolating. So there's one thing with the parent groups, but also it helps to manage negative emotions. It gets to a point, I think, sometimes when the behaviors are impacting family functioning so much that it's hard to see the positives, and it's much easier to focus on the negative. So there's a lot of negative emotions surrounding it. So parent groups can help reduce that kind of thing. Now at school, there's also some educational accommodations that would be recommended. So it would be done through something like a 504 plan. So this is a plan that the school can implement to provide accommodations when there is a disability. So ADHD is considered a disability in the education world. And some of the accommodations that we're talking about would be things like preferential seating to allow the child to sit closer to the teacher in order to maintain better focus. Or it could be things like allowing frequent movement breaks, if the child's very fidgety, having trouble sitting still, things like repeating instructions or clarifying with the child if they got the gist of what to do. So those kinds of accommodations could be outlined on a 504 plan. There are cases in which symptoms may be more severe and they're more significantly impacting learning. And so if there are more intensive support services required, that's when we're sort of talking about an IEP, individual education plan, which would be special education services. And so there are ways to address ADHD concerns through an IEP as well. And so the last thing I will say is that even though in a preschooler, we would start with a lot of these non-medication approaches, there are select situations in which we would start talking about medicine, even for those of the age 3 to 5. And those situations would be if there's significant safety concerns, maybe the child's like running off, eloping, like having trouble controlling impulses in that sense, or if there's aggression or hitting, impulsive behaviors like that. Or if there's threat of removal from a child care program, basically it's like if the symptoms are to a level of severity where things are very, it's almost like crisis mode, right? Then we would talk about starting medicine for that age group.
Yeah, that was so helpful. Sounds like there's so much we can do, even without any medications. You were talking about the fidgeting, got me thinking about all these fidget toys that they have now. It seems like the world is becoming much more, aware of all the differences in the way, everyone's brain works. And, I bet there's, all sorts of parents of kids with ADHD groups on Facebook or, other ways, that families can, reach out and support each other, because it can be really difficult. And like you said, really, really isolating. Dr. Pensa, did you have any other thoughts on what Dr. Ko was saying, or?
That was extremely comprehensive, but I just wanted to add just the basics that we know, but I think are important to highlight. The foundations: sleeping, eating, exercise, and or mindful movement. Some of my patients don't like the word exercise, and monitoring screens. So these are things that are challenges throughout our lifespan, right? Eating on time, eating whole foods, making sure we're drinking enough water, making sure we're getting enough sleep, making sure we're moving. And the big one we all talk about is screen time. So we want to make sure for all kids that parents and caregivers are monitoring this and teaching them the importance of having the balance, but also, and especially for kids with ADHD, because if there are any types of changes in sometimes meal times or a decrease in sleep, it can really heighten symptoms significantly with regard to focus, attention, and sometimes especially impulse control. So make sure that we, as parents and caregivers, are monitoring and modeling what we're doing with regard to these major things: sleeping, eating, moving, and decreasing screens, and making sure that we are encouraging our patients, families, and as parents, our kids to do the same.
Yeah, great point. Yeah. So we spoke a little bit about trying to differentiate ADHD from anxiety or from other social issues. Do kids with ADHD tend to have, other conditions that go along with it as well?
Yeah, so there are other potential comorbidities that are of a higher likelihood than kids that don't have ADHD. And some of them include learning issues. We mentioned that earlier. So different types of learning disabilities, challenges with reading, writing, and or math. There's an increase in the possibility of dyslexia. And there also is an increase in depression, anxiety, and there's a potential increase because of the challenge with impulsivity, substance use issues. So, when we have untreated ADHD in children and adolescents, it does increase the likelihood of some of these things to potentially develop. So getting the appropriate diagnosis and starting the appropriate treatments when appropriately diagnosed is extremely important and can prevent or delay some of the other issues that may come up.
Right. Exactly. I mean, that's a great point too. We worry about the risks of starting a medication, but there's also risks of not starting a medicine, and what are the trade-offs here that we're looking at?
Exactly. And just piggybacking on what Dr. Ko said earlier, in the younger population at 3 to 5, if your kids get kicked out of a preschool or any type of educational environment, it's really important to look at getting an evaluation, potential diagnosis, and looking at medical treatment, because sometimes what happens, especially in younger kids, it's really hard for some of the other behavioral treatments or non-medical treatments to really take hold when we're having such issue with aggression, focus, attention, impulse control. So sometimes just a small amount of a medication can help a child be more amenable to some of the behavioral techniques that are being taught or being recommended.
And Dr. Ko, you mentioned some resources already. Are there any other resources that, you guide parents to check out or that can be helpful to support them in this?
Yeah, so there's always the AAP. They do have a few resources for parents. There's also the Child Mind Institute. They have an entire parent guide as well. And then actually one publication that be a little bit more user-friendly is the ADD Attitude magazine. They have a lot of really interesting articles on there, like how to improve executive functioning and like books for children with ADHD. So like after the diagnosis is made, if you want to have a conversation about what that means, with your child, then you can use a book to start that conversation. So those are some resources off the bat.
Yeah. Dr. Patton-Smith, are there other resources that you mentioned to families?
There's so many others. I do want to highlight the attitude because it really is in very plain speak. They're really interesting, as she said, articles and some really helpful hints. The American Academy of Child and Adolescent Psychiatry has a Facts for Family series that also talks about ADHD and all kind of other child issues as well. And then chad.org is another resource for advocacy for parents especially, but also to help with an understanding of ADHD. And they have webinars and groups and all kinds of things that parents and caregivers can get involved with to learn more and to help themselves educate themselves about the diagnosis.
Yeah. One of the therapists had mentioned before to me a YouTube video actually called Zen Den Cosmic Kids, like full body scan that, it really helps build that mindfulness, awareness, and, just a really good calming strategy. A lot of kids with ADHD have more trouble settling down in the evening, getting ready for bedtime. And we know how important that sleep is. So, the more of it, the better. But I think, really talking to families, I try to talk to them very early about screen time and limiting screen time and, the effects on attention that it can have. So like you said, going back to the basics, are you eating right? Are you trying to stay active best you can? Go for walks, get outside, that can help too. Great. Great. I don't see any questions from Facebook yet. Do either of you have any other thoughts you wanted to make sure that families heard about today?
I did want to add, Dr. Brown, just one thing to what you just said. And I realize this is not a Facebook about screens. However, since it's come up and we're talking about it, this is what I talk to, especially my teenagers. My younger kids, sometimes it's a little bit more challenging for them to understand this, especially my teenagers, where we have a lot of challenges with screens, even though we're now trending younger with regard to screens in general. So when we're looking at someone with ADHD, we already have a challenge with dopamine and norepinephrine getting it to the prefrontal cortex. When we're doing things on screens, primarily video games, but even going through TikTok or Instagram or whatever kind of the latest social media platform is, one thing to keep in mind is a lot of times it's exciting. We like it. We want more. And what happens? We are using dopamine. And when we're looking at dopamine, for it to be active, it has to glom on or attach to a receptor. But there is a finite amount of dopamine receptors, right? We don't just make dopamine receptors because we need more dopamine. So once all the dopamine are on the individual receptors and oversaturated, there has to be a breakdown and a downtime for that dopamine to be then removed or fall off the receptors, and then we start again. Where do we see this a lot? A lot of times a parent will say, my kid plays video games on the weekends for 12 hours at a time, and they become very upset with the video game. They're throwing things, they're upset, they're angry, they're aggressive. It's because they haven't taken that break. And so it becomes very agitating, and they can sometimes become very volatile because what they were doing that was so exciting is just not exciting anymore, and they're getting frustrated. So we all have to take breaks from those screens. And I tell especially my older kids, let's take that dopamine, let's let it reset so that we can all move forward. And sometimes it takes several hours if we have long times on screens, which obviously is not recommended for that to happen. So there is a neurochemical, and I'm really simplifying it, but there's a neurochemical pathway as to why we need to really be able to reduce that screen time.
Yeah. Throw them out the window. I wish. Some days I wish, but yeah, it's
They're
good
here
for
to
all.
stay. We gotta work with them, right? We gotta work with the screens and the screen time.
Dr. Coe, do you have any other closing thoughts?
Yes, I think it's important to remember, and it can be easy to lose sight of, that this diagnosis, it's not from poor parenting. So that's not the cause of ADHD. But also, perfect and good, great, fantastic parenting is not going to fix it either. So it truly is a biological thing going on. It's a medical diagnosis, right? So that's just one thing to remember. And then the other thing is that those who have ADHD, their behaviors often are not from intentional misbehavior, so I do think a big part of this is also recognizing maybe how the child just sees things or how they're learning, or maybe they don't realize that their actions are, it's not intentional necessarily, so that's what I would say.
Yeah, those really important points. So I think if anyone, listening, if you have questions about ADHD, you think your child could have it, I would make sure to reach out to your pediatrician or to your doctor, ask questions, reach out to your child's teachers to get their input on as well. But that's what we're here for, to help, tease through, what's going on and how best support you and your kids in this journey. So thank you all for tuning in today. You can check out more events on our Facebook page or check out kp.org to learn more. But thanks so much for tuning in, everyone.